Hello, everyone. So thanks for being on here. And this is kind of getting into the nuts and bolts, I think, of, there's all these guidelines, how to implement them and theory, but when it comes to the provider having that, 10 to 15 minutes in the exam room to get all this accomplished, certainly for me as a primary care provider, I felt overwhelmed. And in making this video and, in looking at this PEG assessment tool, I've been looking for a quick assessment tool that could be used that does factor in this time piece for providers, because I think you don't have that much time. And this is a simple, 3-question scale. You'll see how I utilize it. I actually get a lot done in 7 minutes. You could even start with just 2 or 3 minutes using this if you are a clinician, and start to kind of assess function, quality of life. It also gives you opportunity to be actually pretty creative with the pain score and set goals. And it's been one way that I've been able to shorten appointments and also train providers on how to do something rather simple, because they don't know how to start the conversation, like someone pointed out. Another pain point for me as a provider has been, or painful point, would be these what we call legacy patients. It's not so much that we struggle now. We know better on new pain patients not to escalate their doses like we did. But we're now, stuck with these patients that 20 years ago we put on these meds, and that's what we were told to do, and we kept increasing these doses. And now we're left with a whole slew of these patients who've been on them for years, and all of a sudden we're supposed to tell them, hey, this isn't effective, and in fact is rather harmful for you. And so as you watch the video, I presented basically a patient of 1,000 that I've seen. The only scripted part is that it's not a real patient, it's an actress. But these are the kinds of things patients typically say. And I'm using the PEG video as you watch as I get through the interview. These were some of the learning objectives. And as you're watching the video, specifically the yellow highlighted areas, watch how I'm setting some realistic treatment goals as we go through it with the patient, where I do end up talking about the risks, the benefits, the function, her quality of life. And then watch just how it's not that difficult for me to, with her concerns and things she brings up, how to kind of redirect her. And I do think that providers can learn how to do this and do it easier than what they thought they could do. And then I want you to watch the confidence that I have with some of these new treatment modalities that are non-pharmacological, with helping this patient and the goals we're setting, because she feels that. And I think that's the number one thing we'll talk about after, take-home point, is provider confidence. If you don't believe the patient's going to get better, they won't. And I think when you have hope, they have hope. And so I want you to really, watch that as we're going through the video. So with that, we're going to play the video.
Hi, Linda. So thank you for taking the time to fill out our 3-item scale that we're using to better assess your chronic pain and understand it. So if it's okay with you, I'd like to go over your answers, and I have some additional questions for you as we start to look at creating your future treatment goals. Would that be okay?
Sure. But does this mean you're going to take away my pain pills?
No, the goal is not to take away your pain pills, but we do need to assess what benefits you're receiving from them, along with the risks and side effects. We do this with all treatment modalities. We now know that chronic pain is actually very complex, and we do have a lot of newer treatment modalities that are more helpful than pain pills alone. And so I will be talking to you about some of those as well.
Yeah, that would be great to hear about other plans to help with my pain.
Exactly. So I'm hopeful that there's some other options for you that are going to help. And let's start talking about your responses. So the first question, what number best describes your pain on average in the last week, right? And 0 is no pain, and 10 is being the pain as bad as you can imagine. So I'm looking at your score, and you answered 8. Is that correct?
Mm-hmm.
Wow, okay, so you're not getting that much pain relief, really, if you're scoring that high at an 8 and you're taking what we consider a fairly high dose. So another way to look at that would be to say you're getting about 20% pain relief from your current narcotic pain pills. Is that what you're expecting from them?
I really expect to be completely pain-free from all of the pills, but I guess I'm just, I've been taking them for so long that I figure I'm just going to be in pain for the rest of my life.
I can see how you would feel that way. What if I told you that some of the other newer treatment modalities we have could give you 30%, 50, 70, 80% pain relief, don't involve increasing these pain pills? Would you be interested in hearing about some of those today?
Yeah, I would. I mean, no other doctors talked to me about this before.
Well, like I said, chronic pain is very complex. As we study it over time, like any chronic disease, things change. We used to think that narcotic pills helped all kinds of pain, and now we know that they don't. In fact, actually, at higher doses, they're harmful and they're not effective for your pain. So we're starting to move towards looking at your function, your quality of life, and not just having you answer a pain score like we did before. Does that make sense? Mm-hmm. So let's move on to your next question, which kind of goes into this. What number best describes how, during the past week, pain has interfered with your enjoyment of life? And you answered 8 to this question. Is that correct?
Mm-hmm.
So out of curiosity, what brings you joy? What do you enjoy about life?
Well, I used to really enjoy being outdoors, like hiking or fishing or gardening. And, now I'm just taking my pills in the morning and napping on the couch all day.
So your current treatment regimen that we're doing right now with just the pain pills is not really helping you enjoy the things you want to do, is what I'm hearing from you. So what if we could start with some small goals today to get you back to enjoying some things in life that you used to do? How does that sound?
I mean, is that possible? I mean, won't I be in more pain with these things?
So I actually have looked at your pain diagnoses and your imaging and other results. And what I actually think in your case is you might be having more severe pain from not moving your body and not doing some of these things. Now, we call that deconditioning. So your muscles now are a lot weaker from sitting inside, right? And I think actually as we start to move you a little bit more, you're actually going to have less pain and enjoy your life.
Okay, but I've always been told if you have pain, you should rest. Where do we even start with this?
Well, I think what's important is you pick something meaningful for you that's reasonable, and we decide on this together. So is there something you could do over the next month or start to work towards that's a small goal of being outside?
Yeah, I guess I could take a walk around the block, and that way I'd be outdoors and in the sun, and then grab my paper on the way back in.
Right, so that's a great goal. That's achievable, and I know that your body can do that. And it may be that the first day or the first week you walk to the end of the driveway and back, and you try that, and you work your way up to a block a day this month, and then we talk about that further. I'm also wondering, though, if you're going to be outside, would you be able to sit outdoors at another time during the day? Just start to sit outside, not exercise, but start to enjoy the outdoors like you used to do.
Yeah, I have these great chairs outside. I could be in the sun instead of just sitting and sleeping on my couch and recliner all day.
Even starting to move from your recliner and sit outside is going to help strengthen some of your muscles. So that kind of brings us to the last question I want to ask you about. What number best describes how, during the past week, pain has interfered with your general activity? So again, you answered fairly high, a 7. So I'm curious for you, general activity, what's that mean for you?
So it's cleaning the house, cooking, doing errands. Right now I just take my pain pills and I'm groggy, so I shouldn't even be driving to do those activities.
So you bring up an important side effect from narcotic pain pills. And I think you're having, some side effects, and also the dose you're on is actually a very risky dose. People die from that dose, even accidentally and from taking it appropriately. So what I want to consider and I want us to do this month is I want to start with a very small dose reduction. And when I say small, I mean if you're taking 8 pills a day, what about 7 pills a day? Would you be able to do that?
So which one are we talking about?
Well, I think that's something you can help choose. So if you take 2 pills 4 times a day, is there one of those intervals that you could take 1 pill instead of 2?
Yeah, I guess midday, since that way, you know, I could work on things like being outside and not just napping during the middle of the day.
So we can talk about that next month. We can see how you're doing. And I'm confident that you're actually going to feel better, that your function's going to increase, your quality of life's going to increase, and your pain is actually going to decrease as we do these. So what I'd like to do at the end of our visit is talk about some of these other treatment modalities with you that I mentioned at the beginning, and maybe you would be able to pick 1 or even 2 to start with this month that I could refer you to. Would that be okay?
Yeah, I'm excited about that, hearing about other things that could help than just the pills. Thanks for really listening.
For some reason, I think a lot of providers think that particular conversation would take 30 minutes for a lot of people. And I think if you use this tool, it makes it a lot easier to address the concerns the patient has, and you can continue moving through it.
I think other providers initially doing this are naturally going to take longer, and they'll just get more experience as they use this patient after patient, et cetera. But initially, it's certainly going to take longer than 7 minutes, my thought anyway.
You know, and you don't have to do all the stuff I did in terms of all that goal setting and tapering and all that initially. I think what you get used to is just using the scale and asking the patient what the scale means to them. And just like, well, what does bring you joy? You know, because once you start focusing on those areas, you know, the patient then starts to rearrange their thinking around pain. So I think that is a very good point. And I wouldn't expect anyone new to the scale to probably be able to use it in that fashion. But you can see how I creatively use the scale to start addressing some of these things, which is what my intent was on that.
Yeah, I just want to make a brief comment on that. You know, I think that when we developed this video, one of the ideas is that if a clinician would be like, okay, I just want to try one question. I'm just going to ask the first question and see if I can, you know, sort of change the way that I respond. And I know that, you know, in the chat bar, you know, somebody mentioned, you know, how do you start these conversations, and you know, the fact that people want to focus on their pain instead of their quality of life. And I think that in that very first question, Rochelle does such a nice job of reframing the answer, where, you know, she's coming in and saying, I've got all this pain, and Rochelle is doing this immediate reframe on, you know, well, you're not getting the relief from this pain medication.
I mean, I would say out of all the patients I've had on high dose MADs, and certainly up to even 1,000 MAD when you get into methadone for chronic pain, I mean, 99% of them are going to answer high on that scale if they're on that much medicine, because over the years, they've become accustomed to it, they're deconditioned, they're still answering above 7, 8, 9. Rarely have I had a patient on very high MAD that answers low on that scale and also has a quality of life and great function. A lot of them are going to score these high scores, and that's the opportunity to really show them, look, you've been on this, it's not helping you that much. And then there are those particular cases that may be the exception. But
I thought the way Rochelle did that was excellent. I use the pain score many times a day, some days. I just used it a few minutes ago. What I find it most helpful in is when I start dosing them down, they come in and they say, oh, I'm terrible. And so I walk them through the pain score. I don't hand them a paper. I verbally talk to them doing the PEG score. And I always get a high, what's your pain, 7, 8. I frequently get that. And when I start talking to them about what they're doing that they like to do, their enjoyment of life, they'll say, oh, well, I went fishing this weekend or something like that. And then they'll give me a score of 4. And then I ask them, well, what about the things you have to do? Well, I got the lawn mowed, and again, a score of 4. Their pain score never drops, but their activity level and their enjoyment of life drops significantly. And then when that gal would have had a PEG score of 7.69, I think, would have been her PEG score. When you get a PEG score that drops to 5, I tell them anything less than 7 is moderate, anything less than 3 is mild. I say, we got you now to moderate pain, and they kind of go, oh, I guess it did work. And then we drop 1 pill again, just like Rochelle does. And I almost never get a drop in the actual pain scoring, but I do get a drop in the others.
That's a really good point, and I think that's what you end up experiencing. If you follow this same patient, she comes back the next month and says, oh my gosh, not only did I walk around the block, like I could sit outside. I went to July 4th with my family and sat there, and all of a sudden those particular scores start to go down. And even though she took 7 pills, maybe that score is still an 8 or a 7, but you're going to dramatically see the other scoring become better. Sleep will improve, depression will improve, activity will improve. And that's a really good point. And that's why it's good to do this, because then you can track it over time.
Yeah, I think, in the world of behavioral health, we would say that is a person who's learning to live alongside of her pain, right? That she may not have her pain score actually go down, but that her interference around enjoyment and general activity would improve. How can you validate the pain level reported by the patient, especially as I have seen a tendency to exaggerate the level out of fear of having opioid dose reduced or other secondary gain?
I think I even wrote it in my takeaway notes. I don't focus so much on the pain score anymore, to be honest, because it is subjective. It may not move anywhere, and they may have fear of them taking, as you saw in our patient, that was her first question, well, are you going to take away my pills? I think as you start to focus on their quality of life, goal setting, function, you might see a change in that score, but like I told the patient, we really don't focus on it as much. My point with her was to figure out her expectations of her pain medicine, and also to figure out and let her know, look, you're getting about 20% relief, which we know for some mostly orthopedic type injuries, that's about accurate. You might get 20% relief from your pain pills. I think there is a lot of fear with these patients, and as you saw with mine, she had fear of moving. She'd been told to take it easy. She had fear of which dose to go down on. Some patients will present with dramatic fears that are interesting. And you deal with those as they come. I don't know if that answers your question or not.
The piece I want to bring up is just to really highlight that for a lot of these patients, they are living on disability. This is how they're making ends meet. And when we start mucking around with their pain score, it is very threatening. And so, that's very real. And we have a whole society that is, a problem. I think sometimes being able to just, often when I was working with providers, I would say, let's just have that conversation. Let's talk about that dilemma. It is a dilemma. And what I think sometimes bringing the elephant to light, right? The elephant that's in the room. The patient's on disability. They know they're on disability. And the thing that got them there was pain. And now we're going to expect them to start having less pain. It's going to threaten potentially a lot of things in their life. So that would be my comment on that, is just let's bring it out in the open, because as we're just talking about, patients' lives can begin to change, and they can learn to live alongside their pain. And hopefully the scale begins to tip, where they begin, I've seen patients say, I don't want to be on this disability anymore, and they begin to work towards having a fuller and more meaningful life.
When I train providers and I work with providers, one of the most difficult, I think, things is when the provider doesn't have confidence and they actually are like, you're not going to be better at my work, or the CDC is making me take your pills down, so I don't lose my license. And the patient really can walk away pretty defeated, and it leads to a lot of other difficult situations. So I would say, in order to promote confidence, yes, as you get some patients that you work with and you see that they improve, also learn these new modalities that are being presented in these webinars, because I've never had a patient that I've tapered down slowly that's become more functional ask me to go back on that higher dose once we've gotten there. And it's not that every person will be tapered completely off. I don't expect that at all. A lot of people are going to be on these the rest of their life, but you want to have them functioning the best that they can with their pain. So provider confidence is very important. The second thing is just get uncomfortable with being uncomfortable. And providers really have a hard time with this. You want to give them a pill and walk out. I mean, I get it. If they start crying or throwing a tantrum, it is really a difficult appointment. And, one analogy that I think is really good is think of it as a parent-child relationship. You're the parent. You took an oath, do no harm, keep the patient safe. When I was a kid, we didn't have seatbelts. We ran around the back of the station wagon back and forth with mom going 80 miles an hour down the freeway, right? Do we do that now? No. If you saw a bunch of little kids in the street doing that or on the freeway, you'd call the police. I mean, we know that that's not safe. And that's the same thing with these drugs. And you can tell the patient, look, we didn't know back then. Now look at all our research. It's the same thing. If you were trying to now corral that 2-year-old that was used to running freely and restrain them, you're probably going to get a tantrum of some extent. And you're going to have to still be safe and walk them through it. And some of those are going to be very difficult. It's okay to be uncomfortable. It's okay to hand them a tissue. It's okay to not give them more pills. The other thing, set goals, and I think those should be around improving the quality of life, not around the pain numbers or other things. And you really have to get to know what is important to the patient. And you may have to start with the smallest of goals and check in with your patient and always follow up on those. Once you start setting them, you will be surprised. The patients come in so excited to tell you how they did, and a lot of times even do more. And so I think that is a very important thing to do with the PEG scale. I think sharing a tapering process, if you do have to do it with a patient, you'd be surprised what fears come up with that. I mean, I had one patient I kept trying to taper who would just basically have a panic attack about it, and it had to do with she was actually had another psychiatric problem going on. She was a hoarder, and it had to do with the pill count. She was hoarding her pills and the count. So I had to decrease her dose but keep the pill amount the same so that then we could deal with the other issues from a psych standpoint. And then she was fine with me tapering, even a lot down. So you end up really trying to have them be a part of it and empower them. And the last thing, ask for help, use your team. The more you have a behavioralist, you have access to addiction specialists, even someone to do an assessment for you. Physical therapy and rehab's now moving to different curriculum with chronic pain patients. Supervisors, peers, things you aren't comfortable with. It is okay to call other people in. And getting used to who's on your team. You don't have to do it all alone. I call in the behavioralist a lot and do warm handoffs with her. There's a lot more behavioralists now getting into primary care. But, understand your community resources, and it's okay to hand those off. Those are the main points I just want to bring home, I think, about utilizing this scale with difficult patients. But I use similar, interview techniques with anyone with chronic pain, and I think or with any chronic condition, actually. Once you get used to a few open-ended questions, your patients really respond.
So we have on our website, QI Collaborative website, there are a section of resources where we've put videos as well as scripts that people can go to and actually print them off, different people. This video is on there. Aaron Krebs has done a really nice job outlining, scripting for difficult conversations. We have some documents that I've put together through our work here in Oregon. So I would encourage you to take a look at some of that if you're interested.
A couple of points about, the medical assistant. I'm very clear with my patients and with my MA about expectations for any appointment and setting those up. People come in with their lists of things and they have a lot to talk about. And then you get new patients who are on all these medications from someone else. And so I typically, have my MA set that up. Like, this appointment is about this. This is what Rochelle's going to be covering. Was there anything else urgently that you want me to tell her you also have? Or we lay out kind of some pre-goals, and then the medical assistant will let me know that or put that in there. They also have a sore throat. Could you check real quick, at the end? Or they have a whole list, Rochelle. Here's the list. And I really set boundaries with those with patients. Okay, we're probably going to be able to address these, and I want to get to these. So we may have to make another appointment sooner than I'm used to making, with you to address these. And I really elicit the medical assistant in helping me do that to corral patients and the time frame of what we're dealing with. And it helps patients to know, like, okay, what am I expecting from this appointment? And I don't walk in just, oh, this is my agenda. I really start to talk to them from the beginning. Were you expecting anything else? And I try to do that just in 30 seconds to a minute at the beginning. And I have my MA really, really help with that. So a lot of providers are struggling with co-pays, and they've got to address their diabetes and their hypertension and at the end of the appointment, the patient will say, oh, I need my refills, right? I encourage dedicated pain visits, at least, when you're starting with a patient or you're looking at tapering or you're dealing with someone on a higher MED for sure. When you're dealing with all those other chronic conditions, you really aren't able to assess, their pain like you need to and with the right exams. I recommend them. Now, if you can only fit them in, a few times a year, then that's what you do. Everyone's a little bit different, but patients love it. If you say, look, I'd really like to take a different appointment just to talk about your pain. This is real. This is affecting you every day. We aren't having enough time to talk about it. Patients are like, wow, I would love to have an appointment dedicated to that. I do think that in the best case scenario, all providers would want dedicated pain visits. That would be in the best situation. And I realize in primary care that that's not always possible. I had an interesting thing, while I was implementing a whole program at my clinic, is I asked the providers for any of their patients on high MED if it'd be okay if I brought their patients in for naloxone training. And we called them ahead of time and got them to bring someone. And what I did during that appointment, because the naloxone training takes about 5 minutes, takes 10, is I did the PEG scale and other assessment, really, and then gave feedback to the provider that they had no idea about. God, how did you get that patient to go do that? They haven't wanted to do anything around pain. And so it is a great way to bring up the conversation about the risks and also to start talking about function, quality of life. And it's interesting what the family members or the loved ones say.
Yes.
Those are really interesting appointments. And I've used the YouTube naloxone nasal spray training video. I think it's 5 minutes, 7 minutes. It's very easy. And that's a great way to start these conversations. A lot of people are like, oh my gosh, I had no idea that these were this dangerous.
Yeah.
Help me get down on the dose.
Right. Kind of hints the piece around the MAs saying, are you still taking that dangerous medication? Let's be real about it. Yeah.
I just wanted to give an example, a quick one about how I use the PEG score. So the first question, what is your pain? I asked them to give me a number. The second two questions are an enjoyment of life and general activity. And I explained to them that enjoyment of life is things you want to do, your hobbies, hiking in the case of the example. And general activity is things you have to do. Instead of giving a number, I asked them to make it a percentage. So if they give me the number of 8, that means 80% of their enjoyment of life is impacted by pain. Or if they give me a number of 4, only 40%, meaning they can do 60% of what they want to. If I happen to get a 4 or a 5, I really jump on that score and say, look you're doing over half of the things you want to do or over half the things you have to do. It gives them a little different view of their pain.
Great. Yeah, just reframing those conversations, I think. Perfect example. Thank you very much, and have a wonderful rest of your day.